Hello everyone and welcome back to our Nursing 106 course and lab. So today we'll be taking a look at gas exchange. We expect you to have completed all your pre-lab work, and we also expect you to have read all your resources as indicated on your unit outline. So read your objectives, and your study has to be guided by listed objectives indicated in your unit outline. As part of our learning outcomes, we'll be talking about, or we'll be emphasizing the ability to teach clients about a certain number of techniques: the breathing, coughing, incentives parameter, and more. We need to be, or you need to be knowledgeable about indications and contraindications for oxygen therapy, because when lungs are not functioning optimally, you may have recourse to supplemental oxygen. Safety matters in all our nursing practice, so throughout your care, throughout the course of care, you want to give priority our safe techniques. So you want to discuss about how you may ensure that oxygen delivery is safe. And you want to be knowledgeable about all the different types of delivery modalities of oxygen. At a certain moment, you may also need to perform oropharyngeal or nasopharyngeal care. It may be suctioning, it may be sample collection, it may be any intervention that is performed through the oropharyngeal. Oral will be through the mouth to the pharynx, nasopharyngeal will be through the nares, from the nares to the pharyngeal area. You want to also be able to demonstrate a safe suctioning technique in upper airway. We're talking about nasotracheal, for instance. That is a technique that has to be sterile. You want to be able to collect a sample, whether it is oropharyngeal or nasopharyngeal. It has to be safe, and it has to be sampled in a way that results will have to be valid when you get them from the lab. Otherwise, you falsify the entire course of care. If you did not document it, it did not happen. So we have to be able to thoroughly and appropriately document provided care and develop or generate a pretty detailed report or follow-up report on provided oxygen therapy. Everything we do in nursing is evidence-based. So our learning outcomes do include the ability to perform a professional care that is built on safety as a priority, also built on holism that would include caring, compassion, sympathy, so that human dimension, and of course care that is dictated by research. Technically we call it evidence-based care or evidence-based interventions. What is gas exchange? Simply oxygen in, carbon dioxide out. What happens? Oxygen from air is inhaled to the lungs through the trachea, bronchi, bronchioli, and then to alveoli. Then from the alveoli, we go to the bloodstream, and from the bloodstream, it will diffuse to tissues, specifically to cells. In the cells, the oxygen will trigger chemical or metabolic reactions where it burns metabolites inside, leading to cellular respiration, of which byproducts include CO2, carbon dioxide, water, H2O, and it's also an exothermic reaction. So it generates energy that can be immediately used for other chemical reactions or physiological reactions. But if it is not used, it is absolutely stopped or stored in the form of ATP. So the CO2 is high in the bloodstream when it's produced. We have to diffuse from the bloodstream to the alveoli, where it will be low in low concentration, and from the alveoli, it will be forcefully sent out to the air out and against the concentration gradient. So diffusion, you learned it from probably high school. It's the movement of particles, molecules, or solutes that can be electrolytes from high concentration area to low concentration area. So this is what happens as the oxygen CO2 travel O2 from the air to alveoli. It's high in air, low in alveoli. It will diffuse to the alveoli. Now, high in alveoli compared to the bloodstream, it will be diffusing to the bloodstream. Then, now high in the bloodstream compared to the cells, then we diffuse to the cells. And then the CO2 generated after the metabolic reactions will be in high concentration in the cells compared to the bloodstream. Then we diffuse to the bloodstream. Then higher concentration in the bloodstream compared to the alveoli. You then diffuse to the alveoli. Then from the alveoli to outside, it will be forcefully expelled and against the gradient of concentration. All right. When you talk about gas exchange, we want our cells and tissues to be well oxygenated. But everything will start from the lungs. If the lungs are collapsed, nothing will get to the tissues. If lungs are infected with pneumonia with a lot of mucus, you won't expect much in terms of oxygenation of the tissues. So we want to prevent atelectasis, we want to prevent pneumonia, we want to ensure adequate perfusion depending on what's going on. So someone may be a post-surgical patient, may have underwent surgery, someone may be just unable to move around, be bedridden, someone may have been smoking for so many years and lungs are kind of altered, the alveoli may be altered in several forms, and all those patients may need help to get gas exchange conditions ameliorated or improved. As a nurse, always use your nursing process as your primary guiding tool. Assessment, assess, assess and assess. Look at the skin. Is it pale? Is it pink? Look at mucous membrane. Is it pale? Is it blue? Look at respiratory patterns. Is the patient using accessory muscles like labored breathing? Is your patient displaying nasal flaring? Is your patient grunting? Right? Is your patient lethargic? Is your patient confused? What do you find? What are your findings from your vital signs? Combine all that information to determine the problem and what is causing the problem, and intervene early. Early interventions are always recommended. Always early interventions before things get aggravated, critical. So your goals have to be clear and smart, right? And each goal has to get interventions that have to be instituted to make sure that that goal is accomplished. Let's take a look at some of the interventions. So to prevent pneumonia, to prevent atelectasis, cough and deep breathing are recommended. Generally, it may even be by protocol, right? But it's from common sense because they help with lung expansion, right? And help preventing pneumonia. Incentive spirometer, teach your patient. So if lungs are not working properly, you want to deliver supplemental oxygen. Check your doctor's orders, maybe standing orders, protocol orders. Again, assess your patient. That patient may have lost muscle tone in the airway. You may establish an artificial airway. Your patient may be breathing not good, maybe on auscultation, you may be hearing crackles, you may be hearing rhonchi. So you may need to suction to get rid of the mucus that is interfering with the flow of oxygen and the patency of the airway. You may suspect collection from maybe the color of the mucus you see or from the odors you smell. Then you want to be able to collect a specimen, know how, and know the techniques you need to use. Now, coughing and deep breathing, that's another technique. So, deep breathing, as coughing, they help with preventing atelectasis and pneumonia. Deep breathing, that's the technique. Sit upright, breathe through the nose, not through the mouth. You breathe out through the mouth, and then slowly when you breathe out, using pursed lips technique. So you want to feel the abdomen with your hands, and you push against the abdomen. So as you stand still, your hands, your chest, shoulders, and they will all upright. It is important that you hold your breath to get the oxygen reach the alveoli and get time to diffuse to the bloodstream and reach your cells. And then when you exhale, do it slowly, as I said. And you can do it, you have to do it 10 times every hour. Now, cough. We call this controlled cough because you don't cough any way you want. If you have an incision, an abdominal post-surgical incision, you want to spline it to avoid dehiscence and evisceration. You don't want it to open up. You don't want the abdominal contents to come out. That's evisceration. You don't want this to happen. So to get started, take 2 deep breaths. You breathe in and out, and then inhale deeply, as deep as possible, to get prepared for that cough. Then you hold that breath in, right? Strongly. Then you forcefully release the breath as a full cough. You want to do this 2 or 3 times every hour. And both techniques will exercise your lung to function, to recover its recoil, its elasticity, its expansion, and this will help prevent atelectasis and pneumonia. So the next is the center spirometer. I can see that the title doesn't show really clear. It's kind of cut off, but that is inside the spirometer. This is the device. So this one, patients may tend intuitively to breathe in to get their work easy. That's not how it works. Teach them that they have to breathe in, not out. They don't have to exhale in. They don't have to push air in. They have to inhale. As they inhale, they'll be pushing up this piston, the blue piston, and you want them to reach a certain volume according to your plans. So when they reach the volume, the mark you will have selected for them, then your goal will be reached. So it's very important to encourage patients to do this every 8 to 10 times an hour. Don't get your patient stuck in bed and enjoy good sleep after surgery. You have to ambulate them early because otherwise they may fall into atelectasis and they can catch pneumonia, which will both compromise tissue perfusion and oxygen. Not only that, infection can lead to sepsis and death, and atelectasis will lead to respiratory depression and cardiac arrest and death. So we have to be serious about these interventions. So when the lung is not functioning optimally, that's where the patient may warrant provision of supplemental oxygen. So you need to know when it is indicated, whether it is temporary, whether it is permanent. So assess and assess. Look at contraindications. Definitely for newborns and people with obstructed nasal cannula passages, you don't want to use this supplemental intervention. So you also want to avoid excessive levels of oxygen, too high levels. They can be toxic. You will learn about respiratory causes, but they can also damage the lungs. Oxygen as a medication can be toxic. And by the way, it is a gas that is flammable. You want to avoid fire when you are giving oxygen here. So when somebody is on oxygen, post a message telling that no smoking is allowed. So when you're providing oxygen, you need to make sure that it is humidified because it is also a dry gas that may cause a alteration or lesions of mucous membranes. So the green device here provides oxygen. So you have how many liters per minute. That's how we get it. So you get it, and you may have also what we call a yellow device that will provide air. So These are other supplies or devices. This is a maximizer, an optimizer. It's a reservoir. And this is a mustache. It's also a mini reservoir too. We also have reservoirs also here. And here, this is what we call also another delivery system that gives you between 80 and 100% of pure oxygen. So it can be life-saving. So we have the face tent mask that we provide 28 to 100%, which is equivalent to 8 to 12%. And this is really comfortable for people who had face burns. It can really help. It will be the best way to use. So we have also simple masks. So we have a video that will give you some details on that. You can watch it. We also have what we call a non-rebreather mask that we have inhalation and exhalation ports, but we also have a reservoir bag. We get to learn about all those details in the lab. So you may want to provide very determined amounts of oxygen concentration, and they are color coded. We call it Venturi valve or Venturi device. So Venturi devices. So masks that are adjoined to these types of valves are then called Venturi masks. So you want to give precise amounts of oxygen concentration. Depending on the color you give, you choose, you know you'll be how much you'll be giving. The green will be 60%. The white will be here 28%. All right. Some patient may need BiPAP. These are machines that will have patients who have hard time to inhale to be assisted. The machine will help them propel oxygen in. But some other patients or the same patients may be retaining CO2, carbon dioxide, which is not good because it can be toxic as well. The machine, when they exhale, they're not exhaling enough, it will assist to exhale more. So these are the patients that may benefit from this device. The COPD patients, people who have what we call sleep apnea, generally obese patients, also those who have hypoventilation syndrome, people who have pneumonia, people who are getting an asthma flare-up, people who are breathing poorly after surgery, and other patients may have a neurological condition that interferes with the entire breathing process, including, for instance, the hypothalamus. That is the breathing center. That is one of the part of the brain that commands the breathing system. So, in some conditions, airways may be compromised either because the patient is not having a sufficient or a strong muscle tone, so the muscle is flaccid, or just the patient is in compromised level of consciousness. So that way you have to establish an airway. So you want to prevent obstruction. This is very important. You have to pull the tongue forward so that air can reach the back. right? So if it is a nasopharyngeal, it goes through the nares. If it is an oropharyngeal, it goes through the mouth. This is an oropharyngeal for the mouth. This will be a nasopharyngeal. So if you are trying to establish those airways or trying to start suction, for instance, too, note the position. It has to be upright. Semi-fowlers, not upright, but semi-fowlers, basically sitting. Position with the head hyperextended to be able to see the nares. So you want to make sure that the insertion of that catheter, that suction, is comfortable. You have to use a water-soluble, I repeat it, water-soluble lubricant. Between suctions, encourage deep breathing and coughing. That's for nasopharyngeal. So make sure that you are pointing to the back or the throat, not to the brain. So for oropharyngeal, make sure that you pull the tongue forward and you get the airway, whatever supply you are using, to the back, and make sure it is safe. Like I said, you may be suspecting infection, and you may need a sample. You may use it. May get it by suction. You may also use it by swabbing. It's upon you to determine what you need to use. But if you have to suction, doing a nasopharyngeal or nasotracheal suction, you want to absolutely use a sterile technique, and we get details of that sterile technique in the lab component of this session. Very important, the container has to be sterile, and you don't want to touch inside because you will contaminate the container. From your assessment, watch the type of secretion it is or mucus it is, check on the odor, check on the consistency, check on the amount, and document everything. Always provide oral care. As you suction, encourage them, as I said, to take a deep breath and cough, right? And get the sputum you are capturing into a sterile container. So you may need to perform a nasopharyngeal suctioning if they are maybe getting a lot of saliva between the cheeks. Make sure that they don't aspirate on those. That's why you may need to get a nasopharyngeal suction.